So let's continue our discussion about the regulation of eating behaviors, looking at things related to eating disorders and the issues surrounding obesity. So when we're talking about issues of feeding disorders and feeding behaviors, we're talking about how the hypothalamus is going to be regulating the loops as relates to the pull to push away responses. And so we have to go back and look at what's happening in terms of receptors. And so when we talk about the eating disorders coming into play, we're talking about how do the receptors, particularly for leptin and ghrelin, going to impact the changes of feeding behaviors in terms of how do I feel hungry or how do I feel full when we have those secondary signals coming into play as relates to the endocannabinoid system. In terms of the endocannabinoid system and the cannabinoid receptors, regulating and modifying the reception and sensitivity to things like leptin and ghrelin and insulin and adiponectin within the hypothalamus, which is going to modulate all of the brain chemistry that comes about as relates to the wanting or not wanting of food, which means that most of what we look at can be treated in terms of a pharmacological treatment, modulating how the endocannabinoid system is modulating the level of sensitivities to these distinct factors. When we look at how these distinct factors are changing, what we're looking at is we're looking at how does the change of the endocrines lead to the change of psychological wants or not wants? And then how does the change of psychological wants and not wants change the relative sensitivity that we have to the wanting to eat or not eat? When we look at this, it's typically going to lead to changes that relate to either excessive weight loss due to starvations, morbid obesity due to constant feasting, or changes of psychosomatic responses as it relates to bingings that come about due to changes of the receptor densities and receptor responsiveness within the hypothalamus. One of the more recent eating disorder issues that have come into the forefront is the binge eating disorders, where the binge eating disorder is more a relationship of receptor responsiveness more than a change that we see in terms of the morphological changes associated with eating disorders. More often than not, it's based off of modifications of energy balance issues and hormonal changes that come about due to the changes of body morphology that we see with the eating disorders, but it doesn't go hand in hand with it. Now, there's a couple of other issues that we have to look at when we look at the eating disorder issues, and we'll look at the prevalence rates here in a second. But the principal issues that we have to deal with is dealing with the sociological and societal issues as relates to beauty. And part of it has to deal with what gets put to the forefront as to what is beautiful in terms of body morphology, leading to the psychological and higher cortical modulations of the responsiveness to the eating disorder, to eating, leading to the eating disorders. So when we look at the prevalence rates, we start off by looking at the fact that in very young individuals, in children, we have a very, very small prevalence rate. And that's partially due to the fact that there is not a lot of societal pressures on children to look a certain way. Now, this issue has changed slightly within the recent uh, data points where we start seeing a slight elevation in eating disorders, but most of the eating disorders that we see with children are coming from familial pressures driving the eating disorders more than societal pressures driving eating disorders. So we have about a 0.1% overall prevalence rate with all children, whereas about a 2-to-1 ratio between males and females. And this 2-to-1 ratio is kind of important because it stays at that, if not more than that, throughout society for all age groups. Now, what ends up happening is that once the children hit the age of 12, there's a doubling of the prevalence rates, and most of this doubling occurs due to the beginning of body image identification, and it has more of an issue with prevalence with females, and we see this with the adolescents as opposed to the juveniles, with the adolescents, where we have a 2.7% overall prevalence rate, where we have about 3.8% of the female population exhibiting some sort of eating disorder, and about 1.5% of the male population exhibiting eating disorder. Now, unlike what we saw with the juveniles, where we saw a doubling of the prevalence rates, we actually see a tripling of the prevalence rates as we move to the later stages of adolescence. This tripling effect that we see later in adolescence comes about because of the increased societal pressures to look like what is put onto magazine covers, without the realization that most of the media that is out there, whether it is social media or regular traditional media, is a misrepresentation of normal body image issues. Most of it is either in terms of the models that we use as the glorification of beauty being an excessively andrified image for both males and females. Most female models that have been used traditionally to exhibit beauty are an indication of what's referred to as an andrified female image, whereas most males that are used as models are an excessive andrified image. And this goes back to the bell curve issues of development in terms of morphology as it relates to gender. And we'll get more into that when we talk about reproductive functions, reproductive physiology. But because of the social pressure necessary to look a quote unquote certain way, what ends up happening is that we start seeing an increase of eating disorder issues amongst individuals. I'm going to show you some older data here in a second, and the data stays relatively stable throughout the population. There's a slight increase within a couple of the data points. But what ends up happening is that because of the social pressure necessary to quote unquote look a certain way, there is an increased responsiveness within the higher cortical functions to override the distinct loops that we see. And so when we start looking at the issues as it relates to adults, that would be anybody after adolescence, the prevalence rates for anorexia is about 0.6 of the population, and it's about a 3-to-1 ratio between males and females. The population for bulimia issues is about 0.6 of the population, and once again, we're looking at about a 3-to-1 ratio between males and females. The binge eating population is around 3.2% of the population, with almost equal distribution between males and females as it relates to the binge eating disorder. The onset for most of these issues occurs at around 13 years of age for females, with a peak of about 19 years of age. And for males, it starts to appear around 22 years of age, with a peak of around 26 years of age. These onsets correspond to two distinct features within reproductive physiology. For the females, it's when puberty is onsetting and the need to have a body image that corresponds to what they are seeing being portrayed as what is ideal for the female. For the males, it corresponds to when you're attempting to attract a mate for reproductive purposes. And once again, it deals with the portrayal of what is ideal for the male body morphology during this time frame. Now, there is a secondary type of bulimia that comes into play, and the secondary type of bulimia that comes into play is what's referred to as exercise bulimia. Now, I indicate here that there's no data that has been reported yet. There is a small smattering of data that's coming into play that gives exercise bulimia prevalence rates of about 2% of the population, with an even distribution between males and females. Now, the difference between bulimia and exercise bulimia is where exercise bulimics use an irrational caloric balance to offset what is being consumed with what is being expended during exercise or activity. So the exercise bulimic is going to be someone who is going to rationalize, not rationalize eating something one day because they're going to be able to do a little bit of activity the next day. The exercise bulimic is going to do excessive exercise for small meal consumptions. We see this exercise bulimic population in higher distributions with people who expend large amounts of time within the gym, and with people who follow sports and fitness regimens throughout their life, where they will start to rationalize the exercise expenditure for the minimalization of caloric intake to be offset by what is being expended. This is not your mom and your grandma and your dad and your grandpa and anybody else in the family sitting around saying, "Oh, I'm going to go for a walk tomorrow. And so since I'm going for a walk tomorrow, I can go and have this piece of cake today." That's not the exercise bulimic. The exercise bulimic is someone who's going to eat the rice pop or the cracker and go and run a marathon to offset the caloric intake from the rice wafer or from the cracker, where there's not a lot of caloric intake, but there's a huge amount of caloric expenditure. For most of the eating disorder populations, the issue here has to deal with societal triggers. And the societal trigger is based off of what is being portrayed as beautiful, and beautiful is not typical. And this whole concept of beauty not being typical is nothing new. We have seen a whole bunch of changes within society, and we'll get into this in a little bit here when we talk about the issue of diet and metabolism and the concepts of fad diets. But what ends up happening is there's such social media and traditional media pressure to look a certain way without understanding that what we're being represented as the typical is not actually typical. Now, there's this media push for body positivity, and it's actually a misnomer and a misconception as to what the issue happens to be, as we'll take a look here in a second with obesity. But what the concept of the body positivity happens to be is the acceptance of the fact that what we have been portraying for too long as ideal is not actually ideal. It's actually too thin, or a portrayal of what we deem as anorexic based off of our BMI uh, calculations as well as classifications of levels of overfatness or obesity. Now, part of this issue leads to the issue of fad dieting, which we're going to talk about in a completely separate presentation. Part of it is the inability for individuals to learn how to eat. That is, where, when, and how much, and how the speed of the meal is going to inhibit the ability for the short loop to initiate the feeling of satiation. And part of this issue around dieting has led to issues surrounding obesity, not just the traditional eating disorders. And so obesity is an issue where body morphology issues come about due to energetic, immune, and metabolic functions all beginning to dysregulate. And as they dysregulate, we start having changes of responsiveness to the hormones that are regulating the short loop and the long loops, which alter our energetic state and alter the rate at which we are going to be consuming food products. So when we talk about obesity, we actually have to talk about it in terms of what's referred to as overfatness. Overfatness is a phrase that I coined in 2010 and published about in 2012, that is related to what happens endocrinologically as we start accumulating fatness that would allow us to have an increased percent body fat that puts us into an elevated BMI levels. So the way in which we epidemiologically study obesity is based off of BMI ratios, and BMI ratios are actually inaccurate to what the actual issue with obesity happens to be. And this is where the WHO, the World Health Organization, has changed the classifications for obesity to use BMI, but use it in relationship to the waist-hip ratio and the percent body fat. As we start to increase body fat, we start changing the way in which the hypothalamus responds to leptin, adiponectin, adipocin, growth hormone, testosterone, luteinizing hormones, progesterone, insulin, glucagon. And what's happening is because we change all of those structures, we stop responding anabolically at peripheral tissues. We start having excessive amounts of inflammation peripherally, and we start changing our energetic balances within the hypothalamus, where we are going to be constantly having a fasting signal even though we're not actually fasting, which means that we have this constant hunger response throughout the day with a reduced metabolic rate. Even though if we were to calculate the BMR off of the estimated BMR levels, we would say the person has an elevated BMR. Now, adipose tissue does increase BMR, but the problem is that the inflammatory responses and the dysregulation to anabolic and androgenic responses modulates that downstream effect at the peripheral tissues to inhibit the total increase of BMR that we would expect based off of the estimated equations. So in terms of epidemiology, worldwide, there is about a 57% population that is obese, overweight. In the United States, it's around 70% that is overweight, with about 30% being classified as being obese. At least 1 in 6 fit into the overweight obese category throughout the world. That number is increasing, and it's increasing not due to what we normally talk about, and we'll get to that here in a second, as it relates to the causes or the root cause of obesity. Now, this epidemiological rise has actually worked its way down into juveniles and into adolescents, where between the ages of 12 and 19, we expect somewhere between 12 and about 20% of the population to be exhibiting some sort of overweightness or obesity, and that number is actually rising. It's now closer to about 20 to 25% is going to be exhibiting the overweightness and or obesity issue, and this is based off of Z measurements within the normal curve distribution of height to weight ratios. Part of this issue with the childhood is that it sets the hypothalamus to dysregulate throughout the lifespan for the adult, and it causes changes to pubertal development and pubertal maturation during puberty, and we'll get to that when we talk about reproductive functions. So part of what's been talked about is this pandemic rise of obesity and this epidemic rise of obesity throughout the United States, and it's taken pretty well in terms of what we actually see. So if we actually look at what occurs in terms of state proportionality of obesity, it started off where there was only a few states where we actually saw a large percentage of the population that is obese. Now, if you notice, over about a 2-decade time frame, we went from having only one state that had more than 18%, to two states that had more than 18% of the population that was classified as being obese, to only having one state that was less than 22% of their population classified as being obese. This rise goes hand in hand with the rise in metabolic onset diabetes, where at the beginning of this curve, what you notice is that there was only one state that had greater than 6% of the population with metabolic onset diabetes, whereas at the end of this, we only have two states that have less than 7.5% of their population with metabolic issues related to diabetes or metabolic derived diabetes. Now, one of the things we have to look at is what's happened over the last few years in terms of this rise of, and so watch the animation here. And as you notice, we have this slow creep. And part of the slow creep has to deal with an increase of caloric density within the food. But the other thing that goes hand in hand with this increase of obesity is a change of behavior issues that surround the utilization of fuel sources as it relates to energetic expenditure. And this is where a lot of people have started using the phrase of exercise as medicine. But part of the issue is that even if we start to exercise the person, we have to get all of the hypothalamic regions to reset to the new norm for their population, for their responsiveness to the changes of energetic demand and expenditure, irregardless of or without regard to the demographics within the populations. And so we usually talk about the issues as it relates to anorexia and bulimia as in terms of a psychological problem. The problem with obesity, anorexia, bulimia is that it's not just a body morphology issue. There is somewhere between 50 and $150 billion spent per year to combat fat related health issues. And you can put this in quotes in terms of fat related because we're lumping both the obesity issues as well as the anorexia and the bulimia issues into this. And it leads to issues of cardiovascular disease. It leads to issues of metabolic syndromes. It leads to issues of cancers. There is a growing population that is at risk, and it's been an exponential growth over the last 20 years. And the exponential growth over the last 20 years is not because of the rise of fast food, even though that is one of the easy targets within particularly the overfat population. And that's because there is a large interaction of several factors that come into play where we cannot dictate that is it a single factor relative to all other factors. And so we have this constant cogwheeling of action in which we have a change of environmental influence combined with a change of familial influence, linking with social factors, combining with genetic influence and hormonal influences, changing physiological underpinning, the social factors and the physiological underpinnings, changing health behaviors. The change of health behaviors combined with the societal factors and the physiological factors changing body morphology. The combination of body morphology changing with health behavior changing with physiological behavior changing, all leading to a change of overall health. Everybody wants to pin it down to a single factor. The problem is that we cannot do what's referred to as Occam razor on this. There is no ability to limit down to the simplest explanation without inducing a logical fallacy. Occam's razor is the indication that the simplest explanation with the least amount of steps that does not involve a logical fallacy must be the correct answer. The problem here is that we cannot get to the point where we eliminate all of the other factors without also causing a logical fallacy within the argument.